Continue to invite Professor Yasser Fouad, Professor of Gastroenterology at Minya University of Egypt, President and founder of the Egyptian MAFLD Research Group, to present his speech entitled Diet and MAFLD. Please, Professor Yasser.
I hope you, thank you, Hepatoma Research, and thank you too. Thank you, organizing committee. I really enjoyed the lectures this night, and I hope everyone is awake now. I will go fast because of the time. Diet and MAFLD, I have nothing to disclose, but as you know all that prevalence of MAFLD or MAFLD is increasingly all over the 30 years to reach about 30% of population worldwide. And we have in the Middle East region the highest prevalence all over the world. It's approaching about 40% of the population. So recently, MAFLD, metabolic associated fatty liver disease, was introduced by Islam et al. 2 years ago, and it's gaining importance because it's a lot of information, research, and debates all over the last years. So what is MAFLD? MAFLD is a metabolic associated fatty liver disease. It's a hepatic steatosis in any patient. It's detected by ultrasound or by liver biopsy in presence of obesity or overweight patient, or in presence of diabetes mellitus, or 2 out of 7 metabolic risk abnormalities. Here we diagnose MAFLD by inclusion criteria. And this is the difference between MAFLD and the older name MAFLD. MAFLD was dependent on exclusion of all other secondary causes of liver disease. So now we are including the parameters of MAFLD syndrome or diabetes and make this diagnosis of fatty liver disease easier. And as we noticed in this paper recently published, all MAFLD patients nearly having MAFLD by old definition, except for few patients with no other factors of liver disease who are diagnosed as non-MAFLD MAFLD. It means that all patients nearly with MAFLD are the older patient with MAFLD. So tremendous amount of research all over the last 2 years proved the superiority of MAFLD criteria versus MAFLD criteria, as you see here in this slide, in detecting a higher incidence of HCC, also predicting the extrahepatic malignancy. And MAFLD criteria was found better than MAFLD in identifying patients at high risk of renal disease. MAFLD also criteria identified a large proportion of subjects in this huge number of patients in Korean subjects who had a higher risk of developing cardiovascular disease. MAFLD identified severity of coexistence of fatty liver disease with other liver diseases in these 2 nice papers. Continuously also evidence proved that MAFLD criteria outperform MAFLD criteria in identifying patients at high risk of hepatic fibrosis. And MAFLD demonstrated high diagnostic ability of fatty liver index in the detection of hepatic steatosis. It was found that FIB4 and MAFLD fibrosis score could confidentially be used to exclude advanced fibrosis in overweight, obese, and severely obese patients with MAFLD. Renaming it to MAFLD increased the awareness of disease among primary care providers and physicians in other specialties. And positive impact on clinical trials was seen nicely in published 2 papers. So many societies worldwide endorsed the MAFLD criteria, including Basel, Middle East, MENA region, Latin American Association, study of liver disease, and Sub-Saharan African position statement, continuous Chinese Society of Hepatology position statement, and groups of nurses, groups of patients, and International Society of Tropical, and many other societies now are endorsing, and a paper published recently in Lancet Gastroenterology with signature of more than 1,000 hepatologists all over the world from more than 130 countries. So it's a well-established name, well-established literature, well-established research, and it's now going a consensus by AASLD and EASL finally to endorse this name or discuss this name. So going back to MAFLD, since no approved medication till now by FDA to treat MAFLD patients, we only have lifestyle modification as the treatment of choice available in our hand in management of MAFLD patients. And lifestyle modification include weight loss mainly through diet control, exercise, and we can add that coffee intake as a lifestyle is one of the interesting changes of life to manage or add it to management of MAFLD. All of us know this pyramid very well, and this pyramid shows nicely that if you lose more than 10% of your weight and you have a fibrosis, this will reverse the fibrosis in the liver. And even if you lose only 3% of your weight, steatosis will be reversed in your liver. So losing weight proved by evidence that it's important to reduce the steatosis and steatohepatitis and fibrosis. But the problem is that people who lose weight, only minority of them will sustain losing weight after the first year. By evidence, it's only 10% of patients who will lose weight beyond the first year and sustain this. So there is a multidisciplinary approach to maintain losing weight, including psychiatrists, family help, and hepatologists. So what diet is important? What diet is convenient to patients with fatty liver disease? If you look at the societies nearly covering the whole world, EASL, ESP, EN, AASLD, APASL, AGA, and so on, they are all considering that the hypocaloric diet is the main or the important diet to manage MAFLD patient. It depends on reduction of diet by 500 to 1,000 of calories per day, targeting to lose about 0.5 to 1 kilograms per week. Most societies also considering that fructose avoidance is important in management of MAFLD, and they encourage the coffee intake, and they encourage reduction of the amount or abstinence of alcohol in some situations and some studies. So MAFLD treatment with diet is important through the mechanisms of weight loss, improving insulin sensitivity, reduction of hepatic steatosis, and reduction of steatohepatitis. So which diet? Is it low carb or low fat? There are many studies focusing on comparison between low fat and low carb in management of MAFLD. And actually, there is a minor difference in favor of low carb diet to manage MAFLD. There is initial promise in consistent results between both, and losing weight here is the key. It's unclear whether the type of diet is important, but actually low carb seems better than low fat in management MAFLD. Ancient times in Egypt, if you go to all the Egyptians, they used to have foie gras. That means that they overfeed the duck or geese to get a fat liver or fatty liver, which was delicious to eat. If we look at the human, they are doing themselves this. If you eat so much carbohydrate, you will get fatty liver, and this depends on that. So carbohydrates are important, and this is not what you eat only, it's also the matter how you eat. So eating snacks is dangerous. And more snacks associated with sugar are also associated with increasing in the intrahepatic triglyceride content. So snacks between main meals are associated with steatosis, as proved in this nice paper. Sugar may increase the insulin level, and insulin level is associated in the study with the steatohepatitis or NASH, and this was published recently in gastroenterology. And this nice study from JAMA network comparing the low sugar diet versus usual diet in adolescent, it found that the mean increase in hepatic steatosis from baseline to week 8 was significantly greater for the intervention diet group with a low sugar diet, from 25% to 17% compared to the usual diet group. So in meta-analysis, they found that the meta-analysis of 10 international clinical trials, low-carb diet is than 50% in patients with MAFLD. 10 studies evaluated ALT and 9 evaluated AST, 5 studies evaluated GGT, and 4 evaluated intrahepatic lipid content. The result was that carbohydrates diet significant reduction in intrahepatic contents, but no significant reduction in ALT, AST. What about non-nutritive sweeteners? There's a lot of debate about this, but they are epidemiologically associated with obesity and type 2 diabetes. And this explained by that the patient with diabetes or obesity are encouraged to take some non-nutritive sweeteners. But this in ALT from Framingham Heart Study cohort, diet soda not associated with elevated ALT after adjusting for BMI. Sugar sweetened beverages significantly associated with elevated ALT in a dose-dependent manner, including after adjusting for BMI. But non-nutritive sweetener may induce metabolic dysfunction through activation of these taste receptors, change in taste preferences, increase the insulin secretion, and increase the appetite in some patients. It may alter also the microbiome and specific effect, particular for aspartame and sucralose. So it's a debate to encourage or not encourage patients to take non-nutritive asides. What about popular diet? Mediterranean diets mentioned very nicely in the lecture in this slide. And Mediterranean diet has a very good evidence to use and endorsed by some societies now in treatment or in a line of management or in lifestyle modification in patients with MAFLD. And ketogenic diets are also studied in very few studies, but has some limitations, and because it's association with the lipid increase. DASH, the diet approach to stop hypertension and focusing mainly in vegetables and fruits with some proteins. It has a problem with tolerance from the patient. Intermittent fasting either daily by 8 versus 16 hours, 8-hour eating and 16-hour fasting. Another approach by 2 days per week fasting or day after day fasting. That's also not tolerated by many patients, and a recent published paper in New England Journal of Medicine a few months ago proved that there is no value of intermittent fasting in treatment of patients with obesity. There is no evidence that the most popular diets, except for Mediterranean diet, are important for management of MAFLD patients. So what about micronutrients or vitamins? Vitamin levels, the liver is involved in transport and storage of many micronutrients. In general, patients with MAFLD have lower blood levels of zinc, copper, vitamin A, vitamin D, vitamin E. So low levels of these micronutrients associated with MAFLD severity, although the mechanisms remain unclear. So vitamin D supplement, I think that the only vitamin used in MAFLD patient and endorsed by some societies is vitamin E. Vitamin E can be used in treatment of non-cirrhotic patients with MAFLD and in patients with biopsy-proven MASH at a dose of 800 international units per day, and trying to check for prostate, because prostate cancer is one of the complications of long-term use of vitamin E, in addition of dialysis also. So when you use vitamin D for a long time, you can check in males for the prostatic changes. So to summarize, dietary habits or dietary management in patients with MAFLD, low dietary sugar, there is a theoretical reason to limit sugar, especially fructose or processed sugar. Non-nutritive sweeteners, there are theoretical reasons to avoid, and in low caloric, low fat or low carb diet, no diet has consistent superiority, although there is some differences, provided simple sugars and total calories are less. Popular diets individualized to patient preference and to consider Mediterranean diet according to some societies. Vitamin supplementation, vitamin E is recommended for non-diabetic adults with MAFLD, but consider risk of complication as I have mentioned before. So what about coffee? Coffee intake. There is a nice meta-analysis published recently showed 2 case control studies, 8 cross-sectional studies, and 1 prospective cohort study included in this. Coffee consumption was significantly associated with a 35% decreased odds of significant liver fibrosis, although it was not associated with change in prevalence or incidence of NAFLD, but significant liver fibrosis reduced, and this was not in NAFLD only. Previous studies showed that coffee intake may be beneficial in other causes of liver fibrosis or liver cirrhosis as chronic hepatitis. What about polyunsaturated fatty acids? It has been shown that reduced intrahepatic triglycerides noticed with PUFA consumption. Also, steatohepatitis improved and insulin resistance improved. The metabolic benefit observed for monounsaturated fatty acid also shown with some cases of some studies. And we have to remember that saturated fatty acids increase the intrahepatic content at the reverse. They increase the steatosis and they increase steatohepatitis. So we may consider PUFA, fish oil, and MUFA, olive oil, in the diet management of patients with MAFLD. MAFLD consider the presence of other etiologies. So MAFLD can be present with cirrhosis, MAFLD can be present with hepatitis or autoimmune hepatitis, and so on. So in patients with cirrhosis, we have different strategy because this patient is different from MAFLD without cirrhosis. Patient with cirrhosis, we have to completely abstain the alcohol and look for sarcopenia because the patient is in need for protein supplementation daily, and it's questionable to encourage weight loss or not according to fat mass in patients with liver cirrhosis. Other dietary change for volume management in case of ascites and sodium, potassium and hypokalemia should be looked for. Detection and treatment of small intestinal bacterial overgrowth and the problem of spontaneous bacterial peritonitis because of the intestinal permeability and the probability of translocation of bacteria. So we have to assess also nutritional status with handicap strengths and objective global assessment and anthropometric parameters in these patients. To summarize, reduce the total energy intake for weight loss for long time sustainability, avoid dietary processed sugar, saccharose, or fructose, reduce or abstain from alcohol, incorporate mono or polyunsaturated fatty acids into the diet, consider Mediterranean diet, 2 to 3 cups black coffee per day, avoid snacking, and this is Harvard plate, and this healthy plate for anyone, not only for MAFLD. And I finish with this slide, and thank you.